Good afternoon, everyone, and welcome to AMPC's webinar this afternoon. We're lucky enough to have a panel of people that have been working on COVID at that industry level. So we've got Dr. Ian Norton, who's going to be able to give us an update around COVID on a global and the Australian landscape at the moment, and some information around vaccinations. We've also got Stacey and Ken from AMIC that are going to give us an update in terms of HR side of the vaccines and what they've been doing in the advocacy space for the industry. And then we've also got Matt O'Brien and Paul Eldridge from Response, who is going to go through our COVID Marshall course. And then at the end, we're going to be able to show you some new and exciting resources that we're going to release today. So we've got a fairly packed webinar. Thank you for all attending. If anyone hasn't used this platform before, we really encourage questions. And to ask a question, you'll see a speech bubble on your toolbar. If you click on that, you can type the question, and at the appropriate point, we'll direct it to the right person. Now, just so everyone is aware, we're going to have Dr. Ian Norton up first. And unfortunately, he does need to leave the webinar because he's got some other appointments. We're lucky enough to have been able to capture some of his time. We're going to go straight to question and answers for him straight up. If there's any other questions that you think of during the webinar, please still send them through and we'll make sure that we get them responded by one of the Respond Global team. So thanks everyone, and I hope you find that this is a very informative session. So Ian, I might hand directly over to you.
Thanks very much, Amanda, and great to be with you all. Sorry I can't, for some reason, share my screen, but hopefully you can hear me okay. I'm speaking today from a park in Canberra, so forgive any background noise that comes through, but a couple of things that I'm going to try and go through in overview, particularly on the current Australian situation and emerging trends globally. I'm going to talk a bit on rapid testing and emerging science in that area that's relevant to the meat industry, and then on vaccine considerations and what we might expect from that area. So on the current state of outbreaks in Australia, particularly doing well, as we have done for so long now. Very heartening to see large amounts of periods of time, up to 50 days in New South Wales and other states. I do feel that this is a continuing trend, still worried slightly by the fact that winter is coming, and as we've said before on previous webinars, it's not that coronavirus is necessarily seasonal, but certainly we have seen an uptick when weather cools, it can survive for longer. It likes drier conditions, less humidity, and also people's behavior changes in winter, especially in the southern states. So as people congregate more indoors, then of course our risk rises. Our major risk continues to be breaches through quarantine, and so as long as those learn lessons from previous breaches, we're watching carefully the movement towards camp settings, the Howard Springs approach, if you like, in other states, and that again will decrease our risk and make it less likely that we'll get a breach out of quarantine into the community. There's an emerging thing happening in Papua New Guinea, obviously quite a bit of discussion happening here in Canberra today on this as well, and seeing how we can support, but Papua New Guinea has an escalating infection rate. A lot of the reason we haven't heard about it up till now is mostly because of lack of testing. It's not that the disease has suddenly jumped out. It's been gradually growing for some time, but we're now finally seeing it because the testing rates are going higher, and it's becoming more obvious. So that is having impact, particularly in Queensland. It's interesting. There's certainly a large number of people who have returned in on fly-in, fly-out work into the north around Cairns, and I know that for sure in Cairns the hospital has just been declared a code yellow, meaning they don't have actually any more COVID beds available because the current policy in Queensland is to admit all people who are positive rather than having them in their own homes, quarantining at home. They prefer to have them inside hospitals if they go positive, and also in quarantine hotels, they don't leave them there. So that's why Cairns is currently full of well COVID patients. The issue across the world it will be the vaccine slowness and vaccine rollout. And when vaccines start to roll out in places like the Pacific and Papua New Guinea, their risks will drop. As the vaccine rollout continues here in Australia, then our risks also drop. And all we can hope for is that we start to see an improvement in the scale and the rollout speed, because currently it's not going as fast as we all hoped. To put it in context, we've went over 100,000 vaccinations done in Australia a day or two ago. Already in places like Chile, they're doing over 100,000 per day of vaccination. So we are behind several other countries in this, and we are watching and seeing how we can support more on this. But I'll get back to that and how this has an impact for you as a 1B sector in a while. The other thing, of course, we're all watching and all interested in watching is the variants. And so the latest on this is that there's certainly the UK variant, which is more transmissible, as we know. It's becoming really the most dominant strain across Europe. It's clearly been the most dominant strain in the UK for some time. It's strengthening in its amount over in the US. The US is doing very well from its vaccination program point of view. But they still have that emerging problem with UK variant. The South African variant is not just more transmissible, but actually can bypass previous immunity. So we do find people getting reinfected if they get the South African or the Brazil variant. They're quite similar. And what is, I suppose, worrying but also expected with an RNA virus like coronavirus is that there is elements of both the UK and the South African variants that have combined together in what's now emerging as the Californian and New York variant. Now they are sort of if you like, a super variant. They've combined the more transmissibility of UK and the more immune resistant South African variant advantages into one single variant. Not unusual for this kind of virus. It can splice itself and add bits from two different infections if the same person has two different variants infecting them at once, and this is how it works. But unfortunately, this is an emerging trend in the US, and we're watching that very carefully. There is a potential ongoing for new variants to continue to develop. This is part of viral survival, and so this is just, to be really frank, it's a race now between the variant emerging and the amount of vaccine we can roll out to the right amount in populations. When it comes to the global rollout, there is a huge lack globally. Australia's in a great position. We have access to almost 100 million vaccines by the time we get through the Pfizer imported vaccine, the CSL producing locally, AstraZeneca for 50 million, and then also they move on that same site to Novavax afterwards. So we have access to a lot of vaccine. But across the world, this is not the case. And so the COVAX or collaborative between WHO and other agencies will credibly give countries in our region about 20% of what they need. And we expect some of that to occur in the next couple of months. So listening today to DFAT, the Foreign Affairs Department here, it looks like we'll be able to provide about 20% through this COVAX facilities from the WHO by April for Pacific neighbors, Papua New Guinea and other places. But that leaves a huge shortfall, still 80% to go. It does sound like DFAT will support up to 60% to those countries as well, but that will not be until at least Q4 this year or even into early next year. So there's still some time to go. And so any of you who require Pacific workers coming into your sites, Pacific Migration Scheme, I'm actually having a meeting about this later on this afternoon here and seeing how we can better support. There is an interesting development on that, and we're interested to hear an update ourselves on how we will quarantine people coming in from Fiji and Vanuatu at home in their islands before they come into Australia, and therefore you don't have to wait for their quarantine to be cleared in Australia. They'll come pre-quarantined from their home countries. So that's a great breakthrough. Maybe if I can move on to rapid testing and some emerging science there. Clearly, we still have capacity across Australia for PCR. That's the gold standard test. But as you all know, it takes about a day at least. For those of you in more rural or remote areas, it may take longer to get a result. But that will remain the case, and there's certainly more use of PCR using saliva-based testing. So it's less invasive than the nasal swab, but you need to know that the sensitivity of that then drops down to about 94% instead of the 100% or so in PCR. There is another test. We saw it come into the country very early on, about March, April last year, called antibody testing. Just so we're all very clear, it is not currently recommended to use antibody testing. It's a finger prick of blood, and it gives you a result quickly and tells you if you previously had COVID infection and if you're immune now. Usually don't get a positive on that until 14 days after infection. There has been some discussion, should we be using that antibody screening test to also check whether you've reacted to the vaccine? And the current recommendation from the US and from Australian governments is not to use that form of testing. So if you have a workforce or a family who have been given a vaccine, we will not be recommending that you then do an antibody test a month later or so to see if you reacted to that vaccine. It's not proven to be useful enough. The third type of test is an area we've worked very strongly with in Respond Global on, which is called antigen testing. Now, this is checking for the protein that you display when you're infected. It's a very rapid test. It takes about 10 to 15 minutes to perform. It's best done through a nasal pharyngeal, so a deep nasal swab, but it can also be done by an anterior, much easier nasal swab just in the very front part of your nose. And it's sensitive up to about 94%. So it's exactly the same, really, as a PCR saliva test. But the advantage is, not like PCR, which takes a day, you can get that result there and then on site. And so there has been a recent release of a paper from the Doherty Institute looking at this. It was published in The Lancet, which is a very prestigious journal, and it was showing that these particular tests here in the Australian context are very useful for the first 7 days of infection. And to be frank, that's when we're most interested anyway. It's when you're most infected to other colleagues at work, and therefore I still think there's a usefulness for this. You could certainly look at keeping it in the back of your mind if you were to ever have an outbreak locally and you needed to have point of care testing to remain open in the face of increasing risk locally, then antigen testing could be an answer. And then finally, to get onto vaccines and consideration for that, because this is really an important area to discuss now, we are working with AMPC and AMIC on a couple of collaborations. And maybe if I can structure it, first of all, support to national consideration. So here, the industry talking together with government and saying, we are 1B. These are what we sort of expect as a meat industry in total. We are considered higher risk. We are, you successfully advocated to be 1B, and I know that Eric's going to go through some of this later on. But I think that national consideration is one part. It is very clear that at the 1B level, where you will be, it will be your local state health department that's most involved in consideration of how to get vaccinated. And to be very frank with you, a lot of them have not thought yet about 1B because they're still concentrating on how to get through 1A and how to get their health workers, aged care staff and others vaccinated first. Then you will be considered. But what we're hearing from them generally in our discussion so far has been they were hoping that we'd be able to get workers to their GP or to a hub run by a health facility. They understand that, of course, if we can communicate well with the workforce and then advocate for them and then bring the vaccines on site, our uptake will be much, much better. And so this is a really great collaborative now between AMPC, AMIC and ourselves to discuss how we can work state by state to discuss this. How do we engage at least with the public health group to say, please consider us a special case. We are a higher risk group. Would you consider coming to our site? And if they haven't got their head around it, or they don't have the logistics, then we can also look at some other practical logistics options where we can help deliver that. I think from the communication side as well, so we're very much supporting a carrot approach rather than a stick, and it's all about talking to your staff. You know your workers better than anybody, and we certainly are going to work with AMIC and AMPC, particularly on communications package that you can use, whether that be a video and infographics and posters. But what we're hearing site by site is that perhaps you've had a lot of that recently and over the last year. Is it not time now when risks are slightly lower to talk about webinars or direct face-to-face, a chance for people who know what they're talking about with immunization to come on site and convene groups, as many as we're allowed in each state at a site, talk to them, answer their questions, try and understand from your work group what their concerns are, try and allay those fears, answer any of those questions and have a really open dialogue about it. Make sure that the industrial representatives and others feel engaged on this as well. And that's the way I think to get the entire group on board. And I think if we can answer those questions and in a scaled way increase that communication package, then we can really engage them and feel like they know what's coming and how it's all going to roll out. I think then there's some specific things we need to discuss per site. Each site is different, even if you have multiple sites, they'll all be slightly different. So having a plan, if we can get agreement, either because the health department are going to come to your site to deliver, or we in Respond Global working with you could support that site rollout, then or your local GP, whichever practice you want to go with, it will require a site visit. It will require some logistics planning, some plans to be put together, and the sequencing of who's going to be vaccinated when and how, and then that site rollout. I think Amanda can explain more as we go through the rest of the hour on the core and the PIP differences between these two, but hopefully that's give you a summary certainly of the current status of COVID, the value of rapid testing, and not to discount that yet. We may still need it, particularly as the seasons change, and then those early considerations about vaccine. It's definitely not too early to be thinking about this. It's only a few weeks away when this will need to be rolled out at the 1B level. Thanks, Amanda.
Okay,
Thanks,
Ian. Sorry, Amanda.
No, you go, Matt.
Yeah, Ian, I was just going to ask a question which has come up from one Amanda Carter through AMPC. Is there anything people need to consider regarding the COVID vaccine and vaccinating for Q fever, and how can they manage this?
So, yes, a great question. Certainly for all vaccines, be this a flu or Q fever, the first thing to remember is that all the health authorities are going to recommend a 14-day gap. So if you do have new colleagues starting at work and they require Q fever vaccination, you need to make sure it's sequenced in a way that it's either 14 days before or 14 days after any of the vaccines for coronavirus. And then also, I suppose, in sequencing, it looks likely, I can't guarantee it, but it does look likely that you will be offered AstraZeneca vaccine for your staff, and that is a 12-week gap between the first and the second dose. So we're all very clear. It's a safe vaccine that's useful in decreasing severe illness and death, and it's also one of those ones which is slightly less difficult to manage because it's a 2 to 8 degrees Celsius. So these are the kind of things that make a difference, and we can actually do it on site, but we can't do it anywhere near a Q fever vaccination protocol. It needs to be 14 days gap.
Okay, thanks, Ian. I have a second question from Chad Steedman. What is happening in first phase industry in terms of engagement with employees and communications? I'm not quite sure what the full context of that is, that question.
Yeah, I think it's a, maybe if I can give it a go, that we asked, because we asked the same question, and listening to the current rollouts, it's not clear. It's not industry by industry specific, and this is why the beauty of AMPC and AMIC working together with us on a communications package is so vital. So you're going to get generic messaging about vaccine and uptake, but that's been given across the community of Australia. From our understanding so far, we haven't seen anything specifically for different industry groups, and we do feel that meat industry is a special case, and therefore we do need to work on how to message properly to the people you know so well, because you work with them. I do think there's another element to this, which is that we need to think about how to sequence that, to not advertise too early because we don't have anything to give right now, but also to say to them, listen, it's fine to give you a generic messages to us, but we as an industry have been working together on COVID safety plans and site-specific security for COVID. And suddenly, in a way, industry in general, I'm talking about resource sector, meat, and everyone else, has almost been forgotten in the discussion about vaccines, because instead of you being in charge of your own COVID safety on site, you won't necessarily even have access to data about whether your staff have been vaccinated if you went through the route of going to your local GP. There's a legal question here. Are you allowed to just walk up to them and say, have you had a vaccine yet or not? So it's a very strange position for industry to be in, where we were put under the microscope and told we have to be COVID safe and all these plans are your responsibility as an industry. And suddenly when vaccine comes out, we're not as involved. And that's why we're trying to address that national engagement.
Great. I have another question from Christopher Torley. How can company employees access approved rapid testing in a regional area?
Yeah, so there is no current access for that. You have to, if you have symptoms or recent contacts, you can go to the local health department and they will offer you a PCR test. It actually has to be a specific request for these rapid tests. You're going to have to engage with a group who can get access to it. So any licensed health provider, be that anybody on the APRA or health registry, so it can be managed by nurses, paramedics, or doctors. But if this is interesting to you and you have a group either who already work with you and you want to do this on site, or you're interested in exploring it, then you'll have to talk to us about how we get you in contact with either a local provider or we talk to that. But it has to be provided by a health group. And at the moment, the state health departments are not offering this point of care. It needs to be done directly by the industry. There's lots of examples of how it's been done in resources right now, or Channel 10 filming the Cube or whatever. They're all using this test, but they've paid for it separately through a private provider.
Okay, I have one further question, and this is on the ongoing vaccination program post this big rollout. Is it likely that vaccinations will become a regular requirement for individuals on an annual basis, sort of similar to the way flu vaccinations are, a seasonal thing?
Yeah, it is. So if I'm a betting person, yes, I think that's likely. I think we may well see either another booster the year after, or the emergence of variants, because we haven't managed to get to the entire world population in time. There may be emergence of new variants that we need to give you a booster to add to the previous vaccine you had the year before. This is very likely. So at the moment, having to do a seasonal coronavirus vaccine, which checks what variants are circulating around the world or in your region, and we create those boosters, and then they're given to the population and to the workforce each year before the winter season hits, north or south hemisphere. Absolutely.
Okay, now I have one final question, and it's from Robert Farrant, and it's from a training perspective. Should we have been involved in the initial rollout? And I'm not sure where that's coming from, whether Robert is industry or department, or but it's I suppose an interesting question. So how's involved?
Yeah, the short answer is yes. If we haven't, well, we have to a point. AMIC certainly and AMPC have done some early discussions. I think this is now our chance to take a next step and really engage both with the national and at the state level with health authorities, and state the case that we need to be involved in the rollout planning. We know our industry well. We know our sites. If you're interested in coming to our sites, we can escort you there and show you how you're going to do it. If not, then can we at least discuss how else we could work with you and get vaccine access so we can bring it to our site and get it put into our people. But as I said, things that have happened here in Canberra are a little different. There certainly hasn't been a whole lot of engagement on this, and this is where some of the pressure is coming on the governments now. But it's not just this industry; it's industry as a whole. They're not singling out red meat in any way. It's that they didn't necessarily think of the occupational side of this. They were thinking more at a mass vaccination at a population level in homes, and they've just not quite thought about the occupational setting, which is a pity. All we can do now is advocate and say, think of us. It's a special case, and we are high up on this risk list. We would like to work with you and look at how it's played out. You can also know that a lot of the planning has actually been done by consultancy groups like PricewaterhouseCoopers and KPMG. So it's not actually been done within the departments itself, which is also an issue, I think.
Okay, thank you very much, Ian. I'll hand back over to Amanda. So I think, it was great. And good luck with your meeting later on. Thank you very much, Ian.
Thanks a lot.
Thanks, Amanda.
Thanks, Ian. We really appreciate you making the time. And for everyone that's on here, we're going to bring Ian in for some regular updates over our webinar series through till sort of the end of June at this stage. We've sort of got some scheduled, which will be great to be able to keep us really informed. So thank you very much for your time. I might move forward and move across to Ken, McKell and Stacey from AMIC, if they can turn their videos on so we can see them. Excellent, thanks, Ken. To give an update on all the great work that AMIC's been doing. Thank you.
Well, I should ask whether ladies first for Stacey, but I'm happy to be guided by her. Stacey, do you want me to go first? Okay.
Yeah, Ken, if you could go first, and then I'll follow on with the COVID Marshall training.
All right, thanks, Stacey. Hello, everybody. Look, Dr. Norton has answered a couple of questions already in relation to issues I was just briefly going to touch on, but I'll just go through it anyway. Firstly, we've been able to confirm from the Federal Department of Health, their particular task force division for the rollout. They've confirmed that under the, as we all know it, the phase 1B, using the term meat processing, that it is covering all meat industry streams except for meat retail establishments. So just to note that it's not just on abattoirs, it's not just on standalone boning rooms. We're talking about small goods manufacturers, other further meat manufacturing operations, and to a degree even wholesale operations. So most definitely all of those have been confirmed as falling under 1B. With respect to the balance, the meat retail establishments, they've confirmed that they're falling on the next stage after that, which is 2A. We, AMIC, and in conjunction with AMPC and a few other stakeholders, have been having direct communication and, in some occasions, regular hookups with state departments. Now, that be a mixture of Department of Health as well as, in some occasions, Department of Agriculture. So with those discussions that have occurred so far, we have firstly highlighted the fact of the meat processing industry priority. Secondly, we have put a number of questions and subjects to them to find out what they have done possibly, or what they have set out as their plan for the rollout in their state. And let me say that some are probably a bit more equipped at the moment than others, but they have all confirmed that they are relying on communication that they're getting from the Federal Department on some issues. Some they're not getting answers from, and funny enough, we've been able to provide that information to them that we've got from the Federal Department. With the issues that have been raised, now these are in no particular order of importance, but I just wanted to go through these, which may create some questions. Firstly, the timing of the rollout, and I know that there have been some messages or some information, whether it be from industry or from the relevant state departments, as to the timing of the rollouts. And look, there's been mention about either next week, the following week. I think the doctor mentioned within the next 2 weeks. I think that's fairly close to the mark. But as we go on, it'll be made much clearer as to the specific dates available for. Now, keep in mind, it's not in relation to meat processing as per se. It's the priority groups 1B, which of course encompasses a number of areas and age groups. So most definitely we are pushing ahead, or the industry stakeholders are pushing ahead with the discussions with the feds and the department, state departments, about us being proactive in the meat processing industry, is ready, willing and prepared to actually have this rollout come to their actual premises, which I'll elaborate a little bit more on that last point. The other aspect which the doctor has answered, I believe, was the interaction with other vaccines. So whether that be the flu vaccine and of course more directly the QVax, the fact is that, yeah, that's the message that's come directly from the states and the federal department, that there needs to be a 2-week gap with respect to those. The studies have not been adequately done overseas or domestically regarding whether that period can be reduced at this stage. With the other issue regarding doctors and nurses that can actually conduct the vaccinations, there is a training program, training modules that have to be complete by them before they can actually conduct that vaccination. So that's something that may or may not cause restriction or barrier as to who's going to be available to be able to perform those vaccinations. And then of course that depends upon the aspects of geographical location and the number of doctors, nurses that are available, and the logistics of getting those people either to the site or at least in the local hubs close to your area. The other thing that has come up, which has probably been a regular question, is in relation to how employers confirm current and prospective workers that have been vaccinated already, or at least for the first stage, let alone the second stage further down the track. So as to evidence of that, it has been mentioned, I believe, by the federal department and by the federal government that the National Immunisation Register will be used for that purpose. But from a practical point of view, it's going to come back to whether the vaccination is done off-site by whoever, practitioner or nurse, that they've provided a paper copy to the worker to confirm that they have been vaccinated. Which leads me to one of the bigger issues, and I'm sure it's something that everybody's asking, or at least has asked previously, is whether to do on-site or off-site vaccinations. The discussions that we've had with not every state department yet, but with a number of them, is that they are not only agreeable to it, but they want to talk about logistic arrangements for that. So with each department that there has been direct communication with, they have said, look, can you provide us the locations of these establishments, and secondly, if it's possible, to get the employee numbers. Now, I just put I know there's quite a few people on this hookup now, and there's some I've spoken to and others may have spoken to already. Let me just say that if you are keen to do it on site, that you can relay that to Amanda and or myself, so that we can formulate that and pass that information on to the particular state department. Because, as I say, they're keen to get the ball rolling. They are happy enough to look at the aspects of on-site. It's obviously the logistic arrangements of it, but the sooner we know who's happy to do that and is maybe started to plan for that, that we need to know that information. And then in practice, when that does occur, it'll have to be the particular site's preparations as to whether it's done internally in one of the buildings or whether it's done externally, and also the fact of determining the numbers, because depending upon your size and number of employees to be vaccinated, it is going to be an issue of how many can be done depending upon a lot of factors. One, as I said, how many practitioners there to do it, the setup of it, and then of course getting through those numbers of employees, but keeping in mind, of course, that it causes the least disruption to the production at the establishment. The other issue that, of course, has come up, not only in discussions but also in the media, relates to workplace relations issues. One being the prominent aspect about whether to able to make it mandatory. And look, that is a very touchy issue. But let me say the federal government are not making it mandatory. At this stage, none of the state governments, let alone State Department of Health, have indicated they're making it mandatory. They haven't done so with the 1A rollout, and as such, it's bringing it back to what an individual site might do, but you need to be very cautious, and we have sent out information, AMIC has sent out information previously to processors and all other sector members that you need to be very cautious in your approach, both from a industrial relations point of view as well as from a discriminatory or potential discriminatory point of view, so with respect to both current and prospective employees. So happy to speak to members regarding that issue, but you need to approach this from a point of view of, if you haven't already, consultation with your employees, like anything else as to possible change or program that you're going to be running. Obviously, this is a community national issue. It's not solely a workplace issue, but the consultation requirements are a necessity. And then, of course, to try and commit as many employees as possible to the program. The one last thing I'll touch on that is, and this is another thing that we've got confirmed from the Department of Health, that does this apply, or is it open for vaccinations if it is done on site, to everybody who's on the site? The answer is yes. So whether you're talking about your admin people, whether you're talking about your engineering, etc., any person on site has been viewed as eligibility for the vaccination if you do it on site. I think, Amanda, I'll just stop there and give the time over to Stacey.
Thanks, Ken.
Thanks,
Over
Ken.
to you, Stacey.
Matt, are there any questions for Ken before I continue on?
There are questions, but we'll wait until the end of everything before we have those.
Okay, great. Thank you. So today I'm just going to give some background to the COVID Marshal online training course and why it was that this was developed. So for those of you who are based in Victoria, you'll be particularly familiar with COVID Marshals. In October 2020, Victoria mandated COVID Marshals in specific industries. The meat processing industry was one of those industries which was required to have a marshal on site at all times, as we were deemed high risk. So COVID Marshals are responsible for monitoring a site's compliance with their COVID safe plan, supporting workers to follow COVID safe practices, and continually improving the execution of a business's COVID safe plan. Under the relevant workplace directions, employees were responsible for appointing one or more workers as a COVID Marshal who were responsible for monitoring compliance and ensuring that the COVID Marshals successfully completed training in accordance with the Department of Health and Human Services guidelines. So unfortunately at the time, the training provided by the Department of Health wasn't adequate or suitable for meat processing or manufacturing facilities. The training provided was specifically aimed at workers in clinical settings and aged care settings, and it just wasn't suitable for our employees. So at the time, AMIC sought permission from the Department of Health to develop our own COVID Marshal training, and the Department of Health committed to AMIC that businesses would be able to use equivalent courses or face-to-face training, provided they are documented and meet the needs of industry. So as an online training program, this course meets the documentation requirements and it's specifically tailored for the needs of industry. The online COVID Marshal training program has been developed specifically in response to the Victorian requirements, but we see it also as useful to be rolled out across plants in Australia, both to train COVID Marshals, but also other staff with responsibility for infection control in workplaces. So supervisors, leading hands, safety officers, anybody with responsibilities for COVID control in the workplace. So I'll hand over now to Matt and Paul to run us through the program, but AMIC are very excited to see this released and think it's a great tool.
Thanks, Stacey. And I can only certainly double down on those comments from Stacey. I think it's a really important thing. Thinking about it from an audit perspective and a business continuity perspective, to have a really good understanding and really good management of the COVID and infectious diseases within your businesses is only something that will help you pass audit and certainly manage risk and mitigate risk of infectious diseases. So yes, this project was in the inception of it was from Stacey McKenna and AMIC. So thanks, Stacey, for coming to us with this. We've engaged response to do some work with us and develop this course. It is now a live course for our membership. You click through on our web page. You see there it's Meat Industry COVID Marshal Train. If you click there, it'll take you through to a registration website. So it's really important for us to be able to do this. And I'll hand over to Paul now, and he can take you through the course. Thanks.
Great, thanks, Matt. And I've got about just under 10 minutes to go through this, so I'm going to give you a quick highlights reel. And as you're watching this, if you've got questions as I go through, then please feel free to chat your questions, and Matt or Amanda, if you want to read them out. I'm happy to be paused as I'm going through to answer a question on a particular spot. So as an AMPC member, you'd click on the main website and they'll take you through to an enrolment form. It's a very simple enrolment form. That'll then go through to AMPC and they'll just confirm your enrolment and we'll get notified. From there, you will get an email which will it'll come from Web Campus. So just make sure that you keep an eye out for that. It may hit your junk mail or spam box. So once your enrolment comes through, it will come into your inbox and you'll be asked to accept the enrolment. Once you come through on your enrolment, you'll come through to a course page that looks a bit like this. This is our online learning environment, which is called Web Campus. And this is your COVID Marshall course. I'm logged in here as an administrator, so I've got sort of high level privileges than what you would have as a student. So I'm going to flick between the two if I need to. And this is a student view. You'll see that the menus are a lot more simple, a lot less clutter. But I'll take you through some of the support type navigation as you first come in. So you'll see down the bottom here a few icons. There's a support icon. So that just gives you a bit of an idea of if you run into trouble with this course, who you can contact and where you can go for a bit of help. You'll see some navigation links which tell you about how to navigate around the course. You'll also see if you've completed your the quizzes. So there's 3 modules, and at the end of each module is a quiz, and you'll see your progress. So it's important to understand that with this course, you can stop and start. You don't have to come through and complete it all in one go. It takes about 1 to 2 hours, but it will depend on your prior knowledge. So if you've done a lot of reading and you're kind of caught up with what's happening in this space, then you might be able to zip through a bit quicker. So I'll go back then to the home page. Finally, the other thing we've included is a resource section. So we've tried to help the COVID marshals out by grabbing all of the resources that are particularly relevant to their particular state. So if you're Victoria, you click on here, and as a COVID marshal, you'll see a whole bunch of resources for you that are particularly aimed at Victoria. And this will vary from state to state. What this does is it tends to save you time. Instead of having to go and browse all the various state departments of health and everything else to try and grab all the things you need to be aware of, they're all here for you in one place, which is fairly handy. So I'll just jump into the course then. I'm not going to go through all the course because, as I said, it'll take you 1 to 2 hours, but I'm going to give you a bit of a highlight reel. What we've tried to do is condense what is often 10 or 20 pages of words, into a more engaging, interactive environment or experience, and just make it a little bit more of a fun learning journey for somebody who's been tasked with the COVID marshal role. So you'll come through, you'll start on the course. The first thing just gives you a little bit of an indication as to, this is the modules that you're going to be covering. You'll see that the design is responsive, so it'll work on a mobile phone or on a tablet or an iPad or on a laptop or a desktop screen. To navigate and click through on the next, we've inserted some videos. So this is a great video from a TED Talks, which talks about coronavirus. And then we come through into some of the interactions that we've built. We talk about known symptoms. So rather than trying to give you pages and pages of symptoms, we've created these little interactive animations where you can hover over and it tells you, this is the sort of things to be aware of. Okay, and if you want more information, there's some more detail included. So I won't go through all of them, but just some of the key ones just to give you a bit of a taste of it. So this is a video we've created. Now, if I hit this button, I can make that full screen video. Again, this is on a phone or a tablet, it'll play quite happily.
There have been large outbreaks of COVID-19 in abattoirs and meat processing facilities across the world, including Australia. So
you'll see the videos have been developed specifically for this industry. The footage is all relevant. The content, the scripting has all been done by us in conjunction with Respond Global. So we've worked with them to make sure that the content itself is accurate. It's accurate for Australia and it's accurate for the industry. I'll show you this as well, just to give you, again, a bit of an idea. So this is a little quiz just to check your understanding of risk factors. So this is high risk versus moderate risk. So if I'm a COVID marshal, I'm learning about being a COVID marshal. I get given some scenarios. So this scenario, Bob's 68, is nearing retirement. He was off work with leukemia last year. And is he at higher risk of severe illness? So if I click yes, it'll kill one of the COVID nasties. And this is back to sort of space invaders from the 80s. So you'll all kind of recognize that. I've just guessed these answers, by the way, as I'm going through. Oh, if I get it wrong, game over, and I get another shot. Continue, it'll go from where I left off, okay? So that just gives you a bit of an idea of, we're trying to make it a bit of a fun and interactive learning environment rather than being very dull. And we've also tried to take, as I said before, those sort of where you see 10 or 20 pages of content that's really heavy reading, and instead we've just broken it up into more simple and bite-sized learning chunks. So if I want to learn about contact tracing, well, what does that mean? So there's not too many words on a page, and then I can click and watch a video. So the video explains contact tracing, and this is being produced by the World Health Organization. So we've collated a combination of, or curated some videos from experts, and we've also built our own with a view that this course is something that helps you to understand the key concepts as a COVID marshal, but without having to wade through big volumes of text. So this is the contextualization for a plan. So you can see you've got the entry facility. So I click on here. These are some things you might want to think about as a COVID marshal for a signing process. For the staff, breakout rooms, maybe think about these things. So these are being developed again specifically for industry to give some suggestions around what you can implement in your business. Now, particularly in Victoria, the businesses are required to have a COVID safe plan, and a COVID marshal is required to make sure that they're managing against that plan. So this gives the COVID marshal a good understanding of some of the things they should have in their business. So this is a knowledge check. So if I click that, I'm going to get 3 attempts on this. So if I get it wrong the first time, I've still got a couple of attempts to get it right. And noting that you can't jump ahead to the other modules until you complete the quiz for module 1. So here's the first question. I've got to get there's 8 questions. I've got to get 80% pass, and I've got 3 attempts. So I'm just going to click on here, and okay. So I won't actually do that because I don't want to fail that. And if I go back out of this now, out of this quiz, so that's the same kind of interactions as we go through. So if I jump ahead to module 3, you'll see we've included that resource in here that we've also pulled out and added as an external resource. And then, here's the 6 easy steps to a COVID safe workplace. So again, we've just broken down that content into bite-sized chunks, and we've included videos and animations and wherever it might be suitable to explain that particular topic. If there's any questions as I'm going through right now, that's Stacey or Matt that's come up?
No questions have come up around about the training, I don't think. Not that I can see, which is a good thing.
Okay. So hopefully you'll see that it's reasonably interactive and engaging. It's not dull and boring, which we've tried to ensure that if you've been asked to do this COVID Marshal program, you don't see it as a chore. It's actually something that's quite useful. As a COVID Marshal as well, you'll have access to this for at least 12 months. So as things change, you'll be able to come in here and you'll be able to grab information and see, what's changed.
COVID-19 has had a huge impact on the way.
So the video's there, and we'll have on the homepage, there's an announcements function. So you'll see at the top here, which is not here now, but there'll be an announcement. So if there's any changes or updates or alerts, and this will actually trigger an email to you as well. So if you're an enrolled COVID marshal in this course, as we go through the year, if something changes or something that there's an alert that you need to be aware of, that'll come through to your phone as an email message or a text message on your phone to say there's a new announcement on the course. So that's pretty much it. I think I've covered most of it. The course will save your progress as you go, so you can stop and start any time. You're not required to go through the entire course all in one sitting. It'll remember where you're up to. I think that's pretty much the main topics.
Yeah. Right. Thank you very much. Well, I've got a few questions here that are probably going to go to Ken, I imagine. They're around the 1B categorisation. It's from a training for people who do training or RTOs, contractors and clerical staff who are on site. Now, are they considered to be part under the 1B, or is it mainly just people from head office who are excluded from the 1B categorisation? So the question is, are all people who work on site, say for example away from a head office, are they and who might come on site on a regular basis, will they be included in the 1B rollout?
Thanks, Matt. Yeah, look, the answer to that is the first part. All people who are working on the site. So again, it doesn't matter. They're not getting into occupational aspects. It's purely a matter of, particularly we're talking about a processing plant site. They've indicated it's everybody.
Okay, thank you. That's so I'm just looking for the next question. Can access to a site be prohibited if the employee, contractor, or visitor have not been vaccinated?
Look, it's one of those where it slightly touches on this aspect about mandatory, and whether you're talking about a worker, current employee, and it could be labour hire even, and they're covered as well, working on the site, or it could be a truck delivery driver, etc., contractor. The fact is that it's as we go down this path, it'd be a matter of what evidence they've got, similar, not exactly the same, but similar to the Q fever scenario, that what evidence have they got that they've been vaccinated. If they haven't been, or I'll deal with that first. If they haven't been, they've been quite honest about it, then it's then a matter of what safety measures or PPE that you may require, other than, as I say, bordering on the aspect, well, look, we can't let you come in unless you have been vaccinated. But it'd be more, let me put it in a safer perspective. If you were to say, well, look, if you haven't been vaccinated, you're going to have to be appropriately complying with the PPE requirements, which is what plants obviously are doing now. As far as with somebody saying, no, I haven't been vaccinated, and no, I don't want to be vaccinated, again, that's the similar answer as to your requirements. So just be very cautious about, at this stage, not applying the mandatory requirements.
Okay, so the next question then that flows on from that, from a registration perspective, how are we going to be tracking who is and who isn't of people, say, that may, like if we're talking about guys from the department or whoever it is who go from site to site, how do we track that registration? Is there going to be some kind of vaccination card, or are we going to have, like the Q fever register, a registration process?
Yeah, what's been mentioned so far at the federal level is to place those who've been vaccinated on the National Immunisation Register. So that's a long-term aspect to keep a record of that, which I believe will be linked to a matter of an app, and that may vary state to state, I think, but that'll be the opportunity there. in the immediate and short term, the issue will be that when they do get vaccinated, obviously it'll be a lot easier if it's on site, so you have that evidence straight away. But if they're vaccinated off site, then they're provided with a I don't know the actual name of it, but a card or paper that confirms that they have been vaccinated. And again, it'll come back to the point of the initial vaccination and of course confirmation of the secondary vaccination weeks later.
Okay, thank you. There was just one thing that I've been reminded to mention, that the as I've said, that the COVID Marshal course is for AMPC members is going to be the cost of registration is going to be and delivery and administration of the course is going to be covered within the project rollout for that. We have costs that this project incurs. So if you're not a member of AMPC and still wish to undertake the training, instead of being immediately sent to register and being able to start, there will be a paywall there. So that's just a thing to consider within that, if there are people who are not members of AMPC who are wishing to do the course. I'll hand back over to you, Amanda. If you'd like.
Great, thanks, Matt.
Sorry, Matt, the price for that paywall, I think participants would be interested.
Okay, so based on the fact that it's a cost recovery model of what it's costing us to put it in, it's costing $89 per registration. Okay, thank you.
Great, thanks, Matt. Just to wrap up and explain a few more of the COVID resources that we have been working on that will be released today, if I can get my screens to work. First of all, we've got the COVID syndicated PIP that's continuing. So this is a pre-approved PIP for any of the AMPC processing plants that want for the Respond Global team to come out on site and have a look at your policies and procedures. They've done this with a number of processing plants so far, and the feedback that we've got has been really positive. They've got a standard methodology, but it can be tailored to what the plant's requirements are. So normally they'll do a bit of a desktop audit over your policies and procedures, and a lot of companies are looking for, that extra 2 or 3% of, where they might be able to make some small changes moving forward. The next part they would normally go through, there's some training that they can undertake with the supervisors and managers if the plants want, and they can also do a pressure test where they'll actually do a walkthrough as though it's with the employees. So it's a great opportunity for you to be able to have that third-party expert come in. They'll also work with your state department to make sure that they're happy, and they use a traffic light system against your risk. So that helps you forward plan for any unlikely or unfortunate events that might come up in the future. So it's a really good program. If anyone is interested, please reach out to either your co-innovation managers in each of your states or to myself, and we can set up a individualized meeting with the Respond Global team. We've also got infographics that we're releasing today as well. So when we send out the finalized version of this webinar as a follow-up, you'll be able to access these infographics, and I'll just open them up for you to have a look at. I love technology, how it always works before an event. Okay, so this is the first infographic, and it's designed to be able to help your supervisors and managers go through the journey of COVID and explain it to any new member, or to refresh some of your workforce on why certain days are critical in terms of the infection cycle. So it's just a really good visual for you to be able to use within your teams, be able to, put it on newsletters or up in your lunchrooms, anything like that. The second one that has been developed is, once again, really using those LL&N strategies that we all are very familiar with being able to use pictures rather than just words to explain what are the symptoms of COVID. So it's just a sort of new, fresh look. A lot of people have been seeing a lot of the generic stuff, so we thought we'd just do a bit of a refresh and a rebrand on them. So the Respond Global team have been fantastic in creating these with us and the response team. So here's another one, enhanced safety features. So just reminding people, and it's a bit more specific to our processing establishments in terms of, you know, staggered lockers, cross-contamination over shifts, washing your hands, wearing your face masks and balaclavas. And the fourth one is how to avoid COVID. So once again, just really nice, clear, simple pictures that you can use in your workplaces. So we'll make sure that these get out to everyone that's been on the webinar. The second one that we've got is one that it's designed primarily to be able to go up on maybe like a TV screen or something like that in your lunchroom. And if it will open, so that it can flick through, but once again, you can print it out, and unfortunately my system isn't playing the game. Oh, here we go, maybe. So once again, it starts with a few more infographics that you can use either individually or on a rolling screen basis. So you're showing the activities of, you know, what are safe activities outside of work and what activities should be avoiding. So, you know, don't cram yourself in the bus, take your own transport if needed, for example. And then how to actually wear a face mask correctly, and how to remove and dispose of it correctly. Then there's a number of questions that will circle through if you have it up on a TV screen, or you can use it within training in your inductions, etc. So there'll be a question and then there's answers to go with those questions. So it's just another useful resource that hopefully plants will be able to use. And another project that is being led by Matt O'Brien at the moment is the business continuity plan. So what we've really seen through this and also the bushfires is the need for business continuity planning. So we're currently working with the response team on developing a COVID plan, or a business continuity plan, which should be quite exciting, and we'll be able to give you more updates on that as we go through. So thanks everyone for today and your attendance. If anyone's got any questions, we'll take those offline, and especially if you've got ones directed to Dr. Norton, we can make sure that we can get those to them. So thanks again, everyone, and a big thank you to everyone on the panelist team today. It's been a really informative webinar.
Thanks, Amanda.
Thanks, Amanda.
Thank you, Amanda.
Thank you.